You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 8th, 2019. This week, a word that harms endothelial dysfunction, statins, overtreatment of hypothyroidism, and an ischemia trial preview. Let's start with words and surrogate markers of health. I just returned from a beautiful trip to Edinburgh, Scotland. I was asked to give a lecture there at the Royal College on words that harm and words that heal. And before I tell you anything specific, let's first set out that even though I have criticized the Scott-Hart trial, the Scott-Hart team welcomed me warmly. I'm thankful for that. I have unforgettable memories from my trip to Scotland. While I was there, Dr. Andrew Flappin kindly shepherded me for a few days. All the while, he was infusing me with the wisdom of a long-practicing NHS cardiologist. As a real clinician, practicing doctor, Flappin often railed against the folly of risk prediction. He told a funny story of patients seen in the emergency department, and when he asked the trainee what is wrong with this person, the trainee responds, "He is high risk." Labeling people as high risk can surely be included as words that harm. Now, the reason I discussed this vignette from the wise Dr. Flappin is as background to a study from the Mayo Clinic on a new way to label people as high risk. A few weeks ago in my clinic, I saw a poor, unsuspecting fellow who had just returned from one of those major medical centers north of Louisville. This patient had many cardiometabolic risk factors. He was taking multiple medications, had poor social supports, and significant anxiety. But of all those things, what was he most worried about? He had, quote, endothelial dysfunction. Dr. Mandrola, what are you going to do about my endothelial dysfunction? I felt like I was in a dystopian sci-fi film. Well, now I see a study from the Mayo Clinic investigators published in the European Journal of Preventive Cardiology. This was a descriptive study of nearly 500 patients who underwent microvascular endothelial function assessment using reactive hyperemia peripheral artery tonometry. The authors tell us that previous observational studies have demonstrated an association between this microvascular endothelial dysfunction and an increased incidence of cardiovascular disease in individuals with minimal traditional risk factors. But in this study, they found that 221 of the nearly 500 patients had an abnormal test for endothelial function, and of these, 21 patients, or 9.5%, ended up being diagnosed with a solid tumor. But of the 267 patients with a normal test for endothelial dysfunction, only 10, or 3.7%, were diagnosed with a future solid tumor. In the baseline characteristics, a higher proportion of patients with endothelial dysfunction were men, and patients with endothelial dysfunction were significantly more likely to be obese and have traditional cardiovascular risk factors such as diabetes and dyslipidemia. Patients with endothelial dysfunction were also more likely to be treated with aspirin, statins, and metformin. White blood cell count was significantly higher in patients with endothelial dysfunction compared to those without. But after adjusting for many of these factors, the authors found that the endothelial dysfunction increased the risk of solid tumors, and they concluded that abnormal peripheral vasoreactivity should alert clinicians not only to the risk of heart disease, but also to that of malignancy in any individual. Now, this study reminds me of the old adage that being alive is a risk factor for dying. I mean, there were 21 tumors in the abnormal hyperemia group and 10 in the normal arm, and this is a group of only 500 patients, and I'm no stats guy, but this is hardly convincing. But even if it were real, could you not do a similar analysis and find that zip code or walking speed or astrological sign might double the risk of cancer? To my friends in these mega churches of medicine and science, I support research into predictors of major diseases, but respectfully ask you to refrain from making overreaching conclusions and giving patients scary sounding conditions that have limited value other than creating fear. Second topic, statins are in the news again. 3 Irish authors have written a piece in the BMJ that reignited the discussion on the use of statins for primary prevention. Now, I'm not sure why the BMJ decided to publish this. I could not find any new data or new reason to wrestle with this topic. But since the news column from Sue Hughes garnered more than 100 comments, it's probably worth a brief review now. First, the Irish authors address the issue of statin use for primary prevention. What constitutes primary prevention is actually a good discussion point. In the days of old, primary prevention meant no cardiac events, no prior ACS, no MIs, no stents. This was a binary positive or negative thing. You had heart disease, you didn't have heart disease. But now, of course, technology has lowered the bar of what it means to have heart disease. Since almost every adult in my city has had a cardiac catheterization, does it count as primary prevention if you are taking a statin and have a 40% coronary lesion? Some say any lesion gives you coronary disease, but others say no, it's still primary prevention unless the person has had an event. Now, for the few adults in my city that haven't had a cath, most have had a coronary artery calcium score or a CCTA. So let's say the patient has a CAC that's non-zero. Does this count as coronary artery disease? And thus, if it does, the statins are for secondary prevention. I don't have the answers here. Now, to the BMJ paper, which is basically a review of 3 systematic reviews of statin use that included only studies in which the patient had no prior heart disease. The authors don't find anything new. The statins do reduce the rate of cardiac events by about 30%, and the effect on mortality is just under 10%, and it just toggles the line of significance. They then show a nice picture of 2 cases of statin use for primary prevention. One is a female with low risk of heart disease, and the other is a 65-year-old man with tons of risk factors. Obviously, because the man with the higher risk factors starts with a much greater absolute risk of a cardiac event, he enjoys a greater absolute risk reduction than the woman who has a very small baseline risk of an event. Said another way, a 30% reduction of a baseline risk of 30% is 9%, while a 30% reduction of a baseline risk of 2% is just 0.6%. So in absolute terms, the man with the risk factors is 15-fold more likely to avoid a cardiac event than the woman. However, let me throw a wrench into this kind of old thinking. Here, I will reference what I think is one of the most important papers on primary prevention and decision-making. It's by Judith Feingold from the group of Daryl Francis. It's in the Open Heart Journal in January of 2016, and I also wrote a column on this important paper, which I will link in the show notes. These investigators used the UK mortality data to calculate the average lifespan gain from an intervention that reduces events by 30%. They used statins in their paper, but it could be any preventive therapy. They then used a Monte Carlo simulation model to calculate the probability distribution of lifespan gain. And I know that sounds complicated, but it's not. For instance, for the average 50-year-old man, the average lifespan gain from statins is 7 months, which is hardly a lot for taking a pill every day. But the distribution of this gain is not uniform. Feingold and her colleagues found that about 93% of 50-year-old men who take a statin get no lifespan gain, but the remaining 7% can gain many years. So think about it. If you have a massive MI or stroke prevented at age 51, you could go on to live decades. But most people don't gain anything, some gain big. Now, crucially, the way the distribution works also affects age and baseline risk. The higher the baseline risk, the larger the fraction that may enjoy these bigger lottery-type gains. For instance, if you double the risk of that 50-year-old, now the fraction that gets no benefit goes down to 89%, and the fraction that gets the big gains, 11%. Obviously, the younger the patient, the more there is to gain versus less to gain in the elderly. Now, the third thing that Feingold and others did in this paper, which was pure genius, was that they went out into the streets of London and asked people how they felt about this lottery effect. And many preferred a chance of a large lifespan gain to the equivalent life expectancy gain given as a certainty. Indeed, a third preferred a 2% probability of 10 years to a fivefold more gain expressed as a certainty of 1 year. The BMJ Irish authors also spent many paragraphs on the potential harms from statins. Again, there isn't too much new here. The Irish authors call for opening up of the data from the cholesterol treatment trialists to assess side effects. Now, I don't claim to know the answers on statins and harms, but after spending weeks researching placebo and nocebo effects for my lecture in Scotland, I am absolutely convinced that nocebo effects for statins are alive and real. Nocebo, not just from the doctor's words, that this drug could have XYZ side effects, but also from social learning, say, knowing someone who had muscle aches from statins or reading about it in the paper. Now, regarding statin side effects, I highly recommend taking a look at a commentary from Professor Rod Hayward at University of Michigan, published in Circulation in September 2017. Hayward comments on the preference-sensitive nature of statin decisions, and to do this, he contrasts the public versus individual decision to take a statin. In other words, we know statins reduce events, and if millions of people took statins, many cardiac events would be prevented. However, Hayward bravely delves into the fact that real people deciding for themselves must factor in the potential harms of the drugs. And while we have lots of trial data showing no significant adverse effects over the time of the trials with statins, typically this is 2 to 5 years, Hayward raises the possibilities of unknowable unknowns of taking statins for decades. He points out that the null can never be proved, and then asks, quote, could being on a statin for 25 years result in a 25% decline in cognitive function, or a 35% acceleration in the decline in muscle health associated with aging? Now, I don't think so, but the question is whether trial-level data is akin to Nassim Taleb's mediocristan, and low-grade cognitive or acceleration of aging from long-term statin use could be in the extremistan black swan type event. Again, I doubt it, but I would take a look at Hayward's piece and think about this. Third topic, overtreatment of hypothyroidism. Now, here is something I'm seeing often. A patient has their thyroid hormone replacement increased and then develops atrial fib. I'm no expert in endocrinology, but I wonder about the temporal relationship between the development of AFib. An abstract presented at the American Thyroid Association meeting suggested that low levels of TSH resulting from overtreatment of hypothyroidism are associated with an increased risk of AF and stroke. Now, this was a large population-based study using data from the VA. The University of Michigan-led research team looked at more than 643,000 veterans who were treated from 2004 to 2017. They excluded patients with thyroid cancer or those who are on suppressive therapy and those patients on amiodarone. Over nearly 5 years of follow-up, AFib occurred in 10% of the patients, so they had a lot of index events. And they found that a TSH below 0.1 increased the odds of AFib by 16%. The odds ratio here was 1.16, and the confidence intervals were significant. And this was compared with euthyroid TSH ranges. Now, the researchers were also surprised to find that a higher risk of atrial fibrillation in those with TSH levels that were greater than 5.5, indicating undertreatment. Here, the odds ratio was 1.18. Now, they also looked at the risk of stroke, but they had fewer stroke events. Rather than a 10% incidence of AF, there were fourfold less strokes at an incidence of 2.4%. But again, For TSH levels that were less than 0.1, the odds ratio for a stroke was 1.16. But even for the TSH levels of 0.1 to 0.5, the odds ratio was still significant at 1.11. Undertreatment of the TSH was also associated with a high risk of CVA. Here, TSH levels greater than 5.5 had an odds ratio for strokes of 1.33. Just a quick comment. This is an observational study and one cannot make causal claims that over or under treatment of thyroid conditions directly cause AFib. But geez, we know from our first days on cardiology rotations that hyperthyroidism is an important factor to look for in patients with AFib. And these data certainly square with some of my clinical observations. So just allow me to posit that careful adjustment of thyroid replacement to as close to euthyroid as possible is likely important in the maintenance of sinus rhythm and may even help prevent strokes. Final topic today is an ischemia trial preview. Now, our nuclear cameras in our office rev all day long, the cath lab too. Cardiology as we know it, that is, symptoms, then stress, then cath, and often stent. This may change dramatically next weekend in Philadelphia. I will have a formal review of AHA and ischemia coming next week, both in the printed word and on the podcast, but since ischemia is the biggest trial in cardiology in my career, I think we should go over some of its basics. The NIH funded this trial, and its costs are estimated to be $100 million. Now, maybe you thought we already had an answer. We had Courage, Berry 2D, and a host of PCI plus OMT versus OMT trials that have been negative. Well, the issue is this. In Courage, patients were randomized after the cardiac cath. So the knock here is that patients with serious ischemia or serious disease were not randomized, and that's why stents did not reduce MI or death in Courage. In other words, doctors were afraid to put really sick patients in a trial where they wouldn't get revascularized. The ischemia trial gets around this in pretty darn ingenious ways. I would take a look at the trial methods paper in the American Heart Journal, and it really does show some of the clever methodology. First of all, ischemia is not just a test of PCI plus OMT versus OMT. It is a more important test of the strategy of early angiography and intervention versus initial therapy with OMT, OMT being optimal medical therapy. Crucially, ischemia randomizes patients without knowledge of the cath before the cath. Second, inclusion in ischemia required the patient to have moderate to severe ischemia determined by a core laboratory, not the doctors at the site. Then, the vast majority of patients had a blinded CCTA for two reasons. One was to exclude severe left main disease, and the other to exclude people without coronary disease, because obviously stress tests can be wrong. Now, there were some criticisms that during the trial, the authors loosened the entry criteria so that patients could be enrolled with a positive stress with ECG alone. But reading the methods paper, I think they have enough safeguards. Primarily, positive ECG stresses were confirmed to be positive by the blinded CTA. Now, the third big point is the primary endpoint of ischemia is going to be challenging and a bit problematic. It started as a simple endpoint of CV death and MI, but because of low numbers of events, an independent committee recommended changing this to a composite endpoint of CV death, MI, hospitalization for unstable angina, hospitalization for heart failure, and resuscitated cardiac arrest. The authors explain that the original plan had this change as a possibility, so we should not be thinking that anything nefarious is going on. But what we should know, however, is that the two endpoints of hospitalization for unstable angina or heart failure are very, very susceptible to subtraction anxiety. Namely, in the ischemia trial, both patients and the clinicians will know that in the medical treatment arm, patients have coronary artery disease with ischemia, but have not even had a cath yet. So any sort of symptom, no matter how minimal that symptom is, will trigger a hospitalization cascade. Fourth point about ischemia is that the authors have published the baseline characteristics in JAMA in February of this year. 8,518 patients were screened and 5,179 patients were randomized. Interesting was that 1,350 patients were excluded for insufficient ischemia, and 1,200 were excluded for having no coronary disease on CCTA. 434 patients excluded for having left main disease. In Table 1 in that JAMA paper, the key fact, I think, is that 86% of included patients in this trial had moderate or severe ischemia, and by CCTA, about 80% had multivessel disease. These were relatively young patients, about age 64, and 23% women were included. The final comment about ischemia is that this is the last stand for cardiology's clogged pipe frame. If ischemia shows that CV death and MI is not reduced over medical therapy, everything changes. Why rev those nuclear cameras all day long? Why cath every positive stress test if doing so does not improve outcomes over just giving patients a basic regimen of generic medications? And we mustn't be misled by the primary endpoint finding. When this trial is shown, if the primary endpoint is positive, but it's driven by the bias-susceptible hospitalization endpoints, then ischemia will have confirmed the oodles of studies before that have indeed refuted the clogged pipe thesis. CV death, MI, resuscitated cardiac arrest, these are the key endpoints because they're bias resistant. Now, even though I am an EP doctor, I have butterflies over this trial. I mean, think about it. Given the billions of people worldwide who have been treated via the standard clogged pipe train of cardiology care, this trial will either confirm our model or it will be the biggest medical reversal ever. So that's it for this week in cardiology. As always, I am grateful that you listened. And remember, if you like this podcast, please tell your friends. Take the time to give us a review or a rating. This helps other people find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.